Good evening, everybody. You're very welcome to the Unspeakable Bits webinar for October. Delighted to say that we've got a very special panel with us tonight on a very special topic, MS and end of life. Our host, Trevis, will go into more details now, but I'd just like to introduce our panelists first to everybody. We've got Nurse Deirdre Hickson from Ireland, a palliative care nurse, who's also a board member of the Irish Association of Palliative Care. We've got Dr. Rosalind Kalb, a clinical psychologist who specializes in MS care and education from America. And then from Italy, we've also got Dr. Alessandra Solari, who is a university in Milan in Italy. So without further ado, but actually just before that, I would just say to people, put your questions. I'm sure there'll be loads of questions and Trevis will try his best to get through as many as possible during it. If you could just put the questions into the Q&A below and not into the chat, and we'll go through those during the webinar. So without further ado, I'd like to pass over to our host, Trevis.
Fergal, thank you very much, and hello. Welcome everyone to this, the penultimate edition of the Unspeakable Bits. As Fergal said, I'm your host, Trevis L Gleason. We've been doing this for a little over a year now. I'd like to thank MS Ireland for their support and giving us a platform to delve into the topics that were once and quite often still considered taboo, but they are a real and an important part of getting over, under, around, and through the challenges of living a life with this disease. As those of you who have been with us for a while now will know, we don't shy away from the difficult topics or the questions here on the program. We've talked about MS and sex, relationship difficulties, finances, and much more. And tonight we're not stopping. We will delve into one of the least discussed topics about living with multiple sclerosis, and that's dying with multiple sclerosis. Death is an inevitable part of living. That's a given, but how MS might play a part, and that's either a supportive role or a leading part in that end of life, well, that's something that most of us with MS have thought about at one point or another. We invite you to submit your questions to the panel via the questions tab, as Fergal had mentioned, not the chat function, and that's at the bottom of your screen. We'll get to as many of those tonight as we possibly can. As Fergal said, our panel tonight is both international and illustrious indeed. We're joined by Alessandra Solari, MD from Italy, Dr. Rosalind Kalb, PhD from America, and palliative nurse care manager Deirdre Hickson from right here in Ireland. And we were sort of talking about it a little bit. Deirdre is probably the one that will most see the irony in the fact that it's a dark and stormy night here in West Kerry, Ireland, and we're just days away from Samhain, the grandfather, if you will, of Halloween, and here we are talking about death. Not to make too light of it, but sometimes a little bit of levity helps get through, and a spoonful of sugar helps the medicine go down, as they say. I want to thank you all for joining us, and I'm going to jump right into the deep end with you, Dr. Solari, if we can. I've gone looking, and I like to think sometimes that if I have a hard time, then Joe Soap is going to have a really hard time finding the difficult, concrete evidence, or even a considered answer to what many would think would be a simple question. The thing is, it's not a simple question at all, and I understand that. But how, and by how much, does a person's life expectancy change because of multiple sclerosis?
Thank you, Trevis, for this question, and thank you, MS Ireland, for invitation on this webinar. I think that it is important to share and to talk about this topic, difficult topic, but important topic. Well, to try to answer to your question, one of the characteristics of MS is its variability. It is a variable disease, as you probably know very well, and the patients know, because not one patient is like another. Even today, that we have more than 20 treatments for these conditions, we know that not all the patients respond in the same way. And for example, people with a progressive disease, since the diagnosis, have a more, let's say, a severe prognosis than those with a relapsing form. And thinking about survival, so this variability that I was talking about regarding the disease also applies to life expectation. So usually people do not die because of MS, but because of complications of the disease. And the studies that have assessed the life expectation of people with the disease have found quite variable results. So life can be shortened between 7 and 14 years, which is a quite huge range. And we have also to say that these studies were performed mostly referring to the before the MD era, so before disease-modifying treatments were available. We are talking about 1993, when we started with interferons and Copaxone. More recent studies, such as those published in Scandinavia and specifically in Finland, have shown that these data have improved. So survival now can be on average between 8 and 9 years. And it is possible that these data further improve. But again, the confidence interval of these estimates are quite huge, because there are some people with a very benign course and they can survive as another person who has not this disorder. And there are people who have a shorter life expectation because they have a severe form of the disease.
And you mentioned that there was the one recent study. For the longest time, there was a Canadian study that was done in the 70s that seemed to be the gold standard there. And then there was this big gap where there wasn't any research. And you mentioned the Scandinavian study there. That would have been a registry study. So that would have been, they would have just been going back and mining data. So that's not even that wouldn't be the gold standard, I guess.
You're correct.
It affects our lives. It may affect the length of our life, and we all know that the best thing we can do is live our lives as fully as we can and focus on the living part. But we're all going to die at some point, and so I think it's important that we hear that currently the data looks like, and we'll talk about it a little bit later, the difference between being diagnosed, 20, 30, 40 years ago and being diagnosed in this last decade as well. So we'll move on from there to you, Nurse Dee. We've got an international audience here, and I know that we talk differently in Ireland about things. So I want to make sure that we get the terms straight here. And I'm wondering if you could give us a bit of a primer. There are two terms specifically that I think that we might talk of differently in Ireland versus, I know, in America and perhaps other places in Europe. And those two terms are hospice and palliative care. So if we could start with hospice first, because I'm certain that means something quite different in America.
And thanks, Trevis, for asking me, inviting me onto the webinar. Delighted to be here with my two colleagues. So in Ireland, a hospice is literally a place of care. So a hospice is the building, and palliative care is the care that's delivered within that building. But palliative care has evolved massively over the last number of years. Like, I started in palliative care in the 90s, and even then it was only patients with advanced cancer that were referred to our services. Now we take everyone that has a life-limiting illness, and we care for patients like that. But I was doing a little bit of reading about the difference between hospice and palliative care, and literally in this country it's a building, it's a hospice building. I know in the States it's you go into hospice care And that is a type of care that's given. I think it probably mirrors palliative care in this country. You are offered palliative care now once you get diagnosed with a life-limiting condition. And that's an approach of palliative care. So then there's different levels of palliative care. There's level 1, 2, and 3 in specialist palliative care. So as you progress through your life-limiting condition, you will be seen by your GP, your public health nurse, your district nurse. I'm not sure what you're called in the States. I suppose a community nurse or
it would typically be hospice nurses there that would,
hospice.
you know, or palliative care nurses. There's not a lot of that community nurse sort of thing here in America there.
Well, the approach would be given by anyone who works in primary care. So anyone who works in the community should be able to deliver a palliative care approach. And that's about improving quality of life. But then when you come to our services, which are specialist palliative care, that's a level 3 palliative care. You come to us when you have difficulty with symptoms that cannot be managed or looked after by your primary care physician or your primary care nurse. So we would deal specifically then with difficult symptoms or symptoms that need extra care. And that goes across physical, the psychological, the spiritual, and the social. So it crosses all of those areas. So we very much promote the multidisciplinary team approach within palliative care at that stage, because as everybody knows, it's a very complex time in somebody's life when they're heading towards their end of life or when they're entering palliative care. So it has to be treated as such, and it's not one discipline can look after all of that. It has to be a multidisciplinary approach. So it's a complex process, and yet we're evolving into promoting palliative care from the very beginning of diagnosis with a life-limiting condition. So it spans the whole disease process. So that people
the whole medical team, dips an oar in and rows this boat to get the patient to where they need, rather than just you're diagnosed with this life-limiting condition or terminal condition in some cases, and then you're off in some cultures into a hospice care or home hospice or whatever. Okay, that's good to know, so that we know we're all speaking singing from the same hymn sheet, as we'd say. So, Dr. Kalb, one of the things that we've come to learn via these unspeakable bits is that forewarned is forearmed. Also, that it's better to talk about the difficult things in advance when possible. So, so how do we have these conversations? Actually, how do we even begin these conversations with our families when it comes to progressing MS and our end of life plans? How do we even start talking with our doctors? I mean, often, if you're talking with your GP about MS symptoms that are getting bad, they're just going to shuffle you back to your MS specialists. But how do we begin these conversations, and when do we start them?
So I also appreciate being here and talking about this important topic. So thank you for the invitation. I want to back up 1 second just to remind our listeners that most people living with MS are going to die from the same things that all the rest of us are going to die from: cancer, heart disease, stroke, and unfortunately, suicide is also a cause of end of life in some people with MS. But what that means is that starting very early on, it's very important for people to not only manage their MS, but to prevent, if possible, and manage comorbid health conditions, particularly vascular comorbid health conditions that we know speed MS progression and shorten life, right? So actually the conversation begins very early on with the healthcare team and with family members. What can I do and what can we do to optimize health and wellness in such a way that life is prolonged as much as possible? And as Dr. Solari said, for most people, life is not shortened. in MS, particularly these days, unless there are some other comorbid health conditions or some of the complications that do occur. So I think the conversations are best started as part of living with a chronic illness, right? And I now consider aging a chronic illness. And so part of aging is talking about how to make the most of our lives as long as we can. And I don't think that's any different for people living with MS. The conversation is, what are my priorities? I don't know how long I'm going to live. None of us do. What are my goals and priorities? Where do I want to set my sights? If I have a partner, how can we talk about this together and make sure that we're living the way we most want to be living? That's the first step. The second step is to approach that difficult conversation about, well, none of us knows when we're going to die. We could get, hit by a truck tomorrow. So what is it that matters to us, to each of us, about the end of our life? Do I want to be buried? Do I want to be cremated? Do I want to have a big memorial service? Do I want everybody to just turn the other way and not pay attention? What are my values around end of life? And thirdly, I think we tend to focus on the person who's dying or maybe dying, but I've spent a lot of my career focused on the needs of care partners and caregivers. And I think end of life for someone with MS is just as devastating for the partner as it is for the person who is facing end of life, because they have all sorts of feelings like, did I do enough? Could we have made this better? Was I a good enough caregiver, care partner throughout the disease? What am I going to do with my care partner role once my partner is gone? Who am I? Once that partner is gone. So I think there are huge conversations that need to happen. And if people have trouble starting those conversations themselves, that's where the healthcare team should actually be proactive. The neurology teams, the nurses, the mental health providers. We don't want people making decisions in a crisis. Never.
So is it something that, let's just say that my wife and I kind of haven't had these conversations yet, but I think we need to, but I don't know how to start. Would I bring that up to my neurologist or my MS nurse and say, it's time to have these conversations? How do I start? Are they trained? Are they ready to have that conversation with me?
I can only talk about the United States.
Yeah, and I'm asking there.
I don't have the broad experience of my colleagues. I think in an MS comprehensive care center, meaning an MS specialty center, which typically is at an academic setting, I think a lot of those people are ready and able to talk about it. And I would hope that if they are personally uncomfortable or unable to have this conversation, that they would make a referral to a mental health professional who can do it. I think when you're outside of a center where providers don't have a network of colleagues, you might run into a brick wall. I mean, you run into a brick wall talking about sex or money or, all of that difficult topic stuff. So I think you're better off, if you're not at a comprehensive center, to find a mental health professional with whom you're comfortable and talk about your own feelings, and also get suggestions for how to begin conversations with family members or a partner, and maybe even come in together and have a mental health professional facilitate what can be a scary conversation.
We're getting questions in already, and one of them was just how vital is the support of a mental health professional, but it sounds like it's nearly as important it is for the neurological specialist. Nurse Dee, there's a question also that I'll pop to you. And I just want to let everyone know we had a little bit of technical difficulties at the beginning. So we started about 5 minutes late. So we're going to continue. We'll be here for an hour. So we're going to run a little bit late here just to prepare. Dee, there were what no, it was all of us. Dee, there was a question about the price of hospice, of palliative care in Ireland. Is that much different than the normal healthcare system here?
No, in Ireland it's free. Yeah. So palliative care in the community. So if somebody's in a hospital setting, there's a team of medical consultants and clinical nurse specialists in every hospital. And then in the community, you have access to consultants and clinical nurse specialists on the ground and social work. And it's free care. And in the hospice, most hospices have there's a portion that are charitable organisations that are affiliated to the health system in Ireland, the HSE, and then there is other inpatient palliative care units that are all run by the Health Service Executive, the HSE.
As I said, we're getting some questions, and make sure that you put those in, and we'll get to them as many as we can. Dr. Solari, I suppose it's important that we acknowledge, as we talked about a little bit, there's a big difference between being diagnosed when I was 20, 30 years ago, or those who are some of the OG, the originals, 40 and 50 years ago, and those who have been diagnosed, say, within this last decade. One of those differences surely is how far and how fast MS might progress because of disease-modifying therapies. And that also means how MS might or mightn't be part of our dying process. As we're going to have to deal in generalities here as we talk about much of tonight's topic, but can you tell me the differences between the two? We'll call them the two generations of MS, and how they might experience what we're all going to experience, but in this case, when end of life and MS come together for somebody who's 60-something years old and has been diagnosed for 40 plus years, and someone who is their late 20s and was just diagnosed a couple of years ago. What's the difference in what the end of life is going to look like?
Yes, for sure, there is a difference in terms of survival because of the use of disease-modifying treatments and improvements also in symptomatic treatments and in rehabilitation, which is very important. When you reach the end-of-life phase, first, I must say that for MS, like for other neurodegenerative conditions, it is quite difficult to see when a person with an advanced form of MS has entered the end-of-life phase, because there might be crises which are resolve, and then other crises which can be due to sepsis or respiratory problems or swallowing problems. What happens during the end-of-life phase, that usually is considered the 6 months before death, in general terms, is that these crises tend not to resolve completely and to be much more frequent. For example, you have much more unplanned hospitalizations, which are bad experiences, which should be avoided for any person, but especially we are talking about a person with MS. What has definitely improved the end-of-life phase is that we are much more prepared to help people who have entered this phase. Considering the MS team, the teams have formed almost the same period when disease-modifying treatments have been introduced. And I think that it is one of the outcomes of these treatments. So before that, we used to make diagnosis and then say, okay, we see you in case of a relapse because you need some steroids, or now it is completely different. And the team is following the patient since the moment of diagnosis communication, which is very important. And I'm sure that you have considered this topic in your set of webinars. But then the team is following the patient. In 1219, so quite recently, there was a publication in MS about the organization of the MS team. And I counted 33 professionals are involved in a different way in these teams. What I was surprised of was the absence of a palliative care specialist who should be a consultant at least, because now palliative care is not considered for the end of life phase, but in a simultaneous care approach, we must collaborate also in the earlier phases of the disease. And this is quite important, maybe also only for a consultation, because it is a difficult diagnosis to communicate. There is a difficult, let's say, family situation. So the team is not able to manage all the issue. Another important thing, because I don't want to take too much time at going back to the end of life phase, is the possibility to have an advanced care plan for the patient. So this discussion that Dr. Kalb has mentioned, also about the future, not the near future, but maybe the very end of our life. These conversations should be considered early during the disease. And sometimes I took from the neurologist point of view, we don't want to see these. The patient is asking for something, but we look in another direction, and we change the topic of our conversation, and we say, okay, but it is not the case to discuss about that at this point. And it is another issue. So when you are in your end of life period, it is important to know what you want, what are your priorities, and how you want to live in the days or months or years that are deserved to you. Because, as I said, prognostication is not an easy task. So we are not, science, medicine is empiric in this sense. So we must be quite honest. It's okay.
No, that's great. And I'm going to go to Dee with that, because that was a great introduction to the concept of the preparedness, I suppose. We've talked about legal matters and financial matters that concern MS on a couple of other Unspeakable Bits programs. So everybody should be doing this. Everyone, as soon as you're married or you have children, you should start having these conversations. You should be paying your life insurance too, but sometimes that gets away from us, and all of it gets away from us. So are there things that all of us should consider in preparing for this, from that sort of planning side of the topic?
Well, I would always see palliative care as about promoting living, and part of that living is about preparing for your end of life. So that conversation starts, and what is your preference? What is your will? What do you want? What would you like to happen? Like what you're saying, Alessandra, it's about being part of that decision-making process. And the Irish Hospice Foundation have a wonderful pack, and it's called the Think Ahead pack. And it really is an excellent resource, and it's a very good conversation starter, because it helps you. There are different elements to the pack. But one of the parts of it is the healthcare directive. It's an advanced healthcare directive, but you don't have to sit down and fill it all in one go. You can leaf through it and look at it and have a conversation with your healthcare professional, your clinical nurse specialist in palliative care, your physician, your consultant in palliative medicine, your neurologist, whoever that may be. And you can have your conversations as you go along about, what you want to happen. Do you want to, if you're having recurrent chest infections, if you're having, if you're on your 19th admission into an acute hospital in 6 months, what do you want to happen next? Do you want to stay at home, and do you want the palliative care team to come in and make you comfortable at home and help you to live out your life, as opposed, we often talk about we don't have a crystal ball, so we can't see into the future, but we can try and help you make the most and live as well as you can in the time that you have at home. So it does allow for those conversations to happen.
I'll ask Fergal to get a link and put that up for everyone to see. And that's from the Hospice Association, is it, you said?
The Irish Hospice Foundation. It's an excellent document. You can download it. I've done it with patients where we've downloaded it onto a computer. We may look at a couple of questions today, and it may be enough even just to do one question. And then, or you can print it out, or you can get the pack sent to you. It's a minimal cost. I think it's €4 or €5. It's not a huge amount of money, but it's an excellent resource. It's a really good pack. It's very informative. It goes through everything, like simple things like the passwords on your computer, your account numbers. It's a very practical resource, and a great conversation starter.
All right, very good. That's great. I mean, we're here. We're talking about things like advanced directives, powers of attorney, wills, legacy gifts, all that. Those are tangible things that we can all do to prepare not only ourselves but our family. Let them know what we're looking for as we all face an inevitable. But there are intangibles too: the emotional conversations, the difficult discussions, the things we might normally think about for maybe 10 or 20 years further into a typical life. Dr. Kalb, how do we prepare ourselves and our family to avoid, I don't know, I'll call them surprises that just might pull us up short when it comes to MS later, toward the end of life, we'll say?
Great question, Trevis, and please call me Roz. I'm not sure how I ended up being doctor here. I think it always starts with the conversations, but I think the healthcare team can be very helpful with things like, well, how will I know if it's the end of life? I remember asking a hospice nurse when my mother, who didn't have MS but was elderly, was in the process of dying. And I said, I've never been with somebody who is dying before. How will I know? And the hospice nurse explained what I would see, what I would hear, what it would be like. And that was extremely helpful to me, right? As a daughter who was having to be with my mom during that. So I think asking MS providers, what might I expect given the symptoms, or what might my loved one go through given their symptoms? What are we likely to see at the end of life? But, I think going back to your question from before, Trevis, about what's different with the current generation versus earlier generations, is that MS care is much more proactive now than it was. So a person living with MS is much more likely to have attention from a pulmonologist early on, or someone is much more likely to be encouraged to be physically active in whatever way they are capable of being, no matter how disabled they are, because that helps with their physical functioning and their stamina. And somebody's going to be paying much more attention to their skin care, particularly if they have bladder or bowel issues, and not just assuming, well, of course the person's going to have pressure sores. They have MS, which was sort of the way of the past. So now, with much more proactive and careful care of all those things, I think end of life looks very different, probably, than it did before. But if somebody, as Alessandra was saying, has recurrent anything, a recurrent chest infection, a recurrent UTI that they can't fix, a skin breakdown that they cannot heal, you can begin to predict what kind of massive infection may, take over the body. And then the conversation is, as it was with my mother, right? Okay, you've now developed pneumonia 3 times in quick succession. We don't seem to be able to control it. Where do you want to go from here? As Deirdre said, and she said, I'm done. I'm ready to stop. But that brings up another issue, because do you have healthcare proxies in Ireland, Deirdre? Do you have a health? So in the US,
You're on mute, Deirdre, just so you know.
Right. Yeah, we have decision support systems. So we have it's a new organization since the Consent Act came into place last year.
Okay, so
Yeah.
if you have written out, you have your living will, you've come up with all of your choices, right? And then you have somebody, presumably, who is going to act on your behalf if you become unable to voice your choices or communicate your choices. But sometimes within a couple, they don't agree. So a person has made a choice, like my mother did, to not keep treating and to die. But then sometimes the remaining partner says, I can't do that. I can't do that. I can't let them go. I want them on life support. I want them to keep living. And so that's why these conversations are so important, because if I said to my partner, this is what I want, and my partner said, I just can't do that. I couldn't let you go. I would have to keep going. Then I would say in this country, then I need a different health proxy. I need somebody else to speak for me who can act on my wishes. That's a tough conversation.
That's a very tough conversation. There was a question that came in reference to post-mortem donation of organs. And I think that's going to be jurisdiction by jurisdiction. I think even in America, different states can have different rules on some of that when it comes to medications you've been on and all. One thing that I do know is that there are a couple of brain banks that if you're interested in specifically in MS research, you can donate your brain and even your spinal cord tissue to those brain banks, and we'll find the information. We'll put it in the links that will be below once this gets down to the YouTube, which it will be in the next day or two. We'll have this up. So I want to move on now so that we can spend as much time as we can to the reason that many of our viewers have actually tuned in. They're almost folkloric, those inverted commas, those complications of MS, that it's almost like every single one of us have heard from somebody that their sister-in-law's uncle's niece had died from MS or died from complications of MS. Or we hear that if someone prominent may have lived with MS and died of complications of their disease. It's like, well, what the hell are these complications? And I joked about it while we were waiting on beforehand, that when I went looking a lot of the things on the web that talk about these complications, unfortunately, I'm the one that's written about them. I mean, there's just not that much information. And I must say at this point, actually, that Roz, you are part of the reason that this is actually happening, because back in the day when I was in America and you were with the National MS Society, you were the one that helped us begin this conversation in a series of blogs that we called the Unspeakable Bits. So you and I have been at the beginning of this, so I'm certainly thankful of that. But I want to get on to what those complications of MS would be. And, we talked a little bit about pulmonary stuff, but, obesity that's caused by not being able to get out and move can cause diabetes, which then can be a contributing factor to death, or heart disease, or cancer, all those things. So they can be slightly related to MS. So I want to go from what I've read most to least, I suppose. And I'll ask all of you to weigh in on them as you care to. Maybe we'll start with you, Dr. Solari, on this, because you brought it up. Pulmonary involvement. I suppose that's, if people are having breathing issues, cardiac issues, because let's make sure that we understand this. Everyone understands this. It is exceptionally rare that the disease multiple sclerosis directly affects a pathway to an organ and it shuts down. And so a direct MS lesion is probably almost never causes death. It's those extended symptoms, etc. So how is it, Dr. Solari, that pulmonary involvement, our breath and our heart are affected?
Thank you. There are different ways. One is your muscles in your respiratory muscles, so your thorax and your diaphragm, they must move. So if you are feeble, you are not expanding your thorax enough, you are subject to more difficulties in exchanging the oxygen. So this can be a mechanical problem. And as Rose said very well, it is important to exercise, to move, or to have rehabilitation. If you can't move because you are on a wheelchair, to have in any case rehabilitation and have respiratory rehabilitation. Other problems can be due to food ingestion. So if you cannot swallow very well and the food goes into the trachea and into the lungs, then you can have an infection that is due to the food that has entered your lungs, or infections due to the fact that you are not so well from an immunological point of view, so you are more frail and you are more susceptible to infections. So these are the three main mechanisms for these problems, respiratory problems, and there are ways to treat these. So you can have rehabilitation. You can be aided in your respiration with non-invasive masks, for example, or more invasive measures. And you must decide also if you want to go on and when you want to stop with these. So these can be one topic in your conversations. And I would like to go back to one point from Rosalind. Sometimes the proxy decision maker, the best proxy is not the partner. Sometimes it's another person that is very close to the diseased person, but who can, of course, be more, let's say, rational when having to help the staff, the medical staff, to take a decision. And in your plan, another point that is important, these preferences are stated So this is a document, that is important, as well as the decision maker when the patient is in the event the patient is no more able to make a decision on his or her own. And last point that I would like to underline is that advanced care plan is an open conversation, is not an on-off decision, and for this reason, I think that the neurologist can be important, but because neurologists have a relationship with their patients, and during this conversation, they understand much more their patients. So even the day after decision can be different, knowing better the patient you have.
You know, what you bring up there, it's something clicked. You know, the penny dropped, as we'd say here. It's fairly uncommon that your spouse or your partner is going to be the person that's the executor of your will, your last will and testament. Usually, that's someone a little bit outside that decision-making process. And no one seems to have an issue with that. But we put someone exceptionally close to us at an even more difficult time when that was just a bright flash of the obvious for me. So thank you for that. Ros?
Can I just throw something in here? Because I kept, over the years that I worked at an MS center, people drew lines in the sand all the time. So when people were young and pretty newly diagnosed, they would say things like, well, if I end up in a wheelchair, I'm done. I just don't want to live anymore. Or if I can't work, I'm done. Or if I can't play sports, I'm done. People get a little older, their MS progresses, they discover adaptations, they discover that they can do new things or old things in a different way, and the line in the sand moves. And I think it moves over the whole lifetime. People learn to adapt and cope and thrive even well past the point where they thought they couldn't stand it. And one patient I worked with taught me a whole lot. He was completely disabled. He could move one hand. And he said to me one day that the point at which he became truly depressed was when he realized that he couldn't end his own life if he wanted to. And at that point, he felt less than human. He felt diminished because it was no longer in his control. And that taught me a lot.
Yeah, I refer to it as that bad conversation. And we all have if it gets that bad. But that bad moves. It shifts, because I think we all grow to adapt in our lives without MS even. And speaking of that, Dee, we were talking about pulmonary involvement. We were talking about breath and how that can be end of life. And Roz brought up a really interesting point that I thought, when many of us have seen relatives or close friends in those last days, etc. And while it might not be MS specific, what kind, and I know that everyone's experience with life and with death is different, but are there other diseases that you can say, well, here's what pulmonary end of life kind of conditions, this is what brings that in. Is there anything that we might have experienced with a loved one, watching them pass over, if you will, that you might equate, that we might can say, oh, that's what pulmonary involvement means?
Well, I'm open to correction, but I think if you're talking about, repeated chest infections or aspirate pneumonia, a lot of the symptoms that come from conditions like that would be, you've got a sepsis, so it's controlling temperature, and you may have breathlessness. And we have lots of medication that we can use to help control those symptoms at the very end of life. You can have chesty secretions. Again, we have we have many of drugs that we use in order to try and make those secretions less bothersome for people at end of life. In my experience, we've become, and I've worked with some amazing medical consultants down through the years that I've learned so much from, and it's about preempting a lot of these symptoms. So, you know, it's recognizing. So we're very lucky in Ireland. We're very highly trained as clinical nurse specialists, and we work with equally very experienced medical consultants. So we have, our main aim would be to recognize these symptoms before they become problematic. So it's early detection and treating. So keeping ahead of the symptoms all the time, as opposed to waiting for them to become bothersome. So maybe your experience of being with a loved one when they're dying and they're having respiratory symptoms may not have been very positive, but thankfully we've become really good at managing these symptoms at end of life. And I'm very proud to say that I'm part of a team that can, you know, we can hold our heads up and say, yeah, we've got really good at this.
That's comforting to know. One of the things that was brought up in questions, and Ros, you brought up with you know, the ability to end one's life. I remember when I was leaving Seattle to move here to Ireland, a death with dignity law came into fact, but it had to be within 6 months of what was diagnosed as what was probably going to be the end of life, and it had to be self-administered. And as you and I know, if a person is within 6 months of end of life because of MS, they're probably not going to be able to self-administer anything. So the point was moot there. But suicide and or assisted end of life, death with dignity, those are two very separate things in my head. One is a medical plan, and one is maybe I'm simplifying an emotional reaction. I think that those are two different things of deciding to end one's life because that's been part of the plan, and then depression, et cetera, can come in and it can be reactive. Could you talk a little bit about end of life because we ended ourselves?
So I think there's a lot of overlap in the groups that you're talking about, Trevis. I think there are people who are not severely depressed, who have reached their personal line in the sand, have made a decision that the quality of their life is no longer worth the effort and energy it is taking them to sustain it. And they make a decision to want to end their lives. And if those folks are fortunate to live in a place where they can get help doing that, that's awesome, but it's not very available in our country, at least. But I think we do have to pay attention to the fact that depression and its coexisting anxiety are very common symptoms of MS. They're not just a reaction to life with this disease. And untreated depression is the most common risk factor for suicide. Fortunately, we've moved beyond, I hope, the days where people said, well, of course she's depressed, she has MS, or of course I'm depressed, I have MS, who wouldn't be? That's the wrong answer. Depression is very, very, very treatable. But today, the rate of suicide in MS is twice that in the general population. I know that's true in the United States. I don't know if that's true worldwide. But it means that for a combination of reasons, we are not either helping people move their line in the sand by helping them adapt, or we're not treating the depression that robs them of their comfort and quality of life. So that's one of the big complications, along with pulmonary function and skin breakdown and massive infection that takes over the body, that can contribute to shortened lifespan in a person with MS.
And this is an exceptionally timely topic. As Deirdre will know, here in Ireland, it was just last evening, our Parliament got a report from a bipartisan committee, or tripartisan committee, actually, all parties, that looked into assisted dying in Ireland, came out with a report, and the Parliament decided to vote to note the report. So we're a long way from any decisions, but for those of you who are in Ireland, and if this is an important topic to you, certainly is to me, I would recommend that you get in touch with your TDs and tell them how you feel about it. We're coming up on an election, so this government certainly won't be picking up the ball. But if it's important to you, do get in touch with your TDs, and when they come to the garden gate, have a conversation about with them. One of my local TDs was chairing that committee, and his representative and I had a very heated conversation about his opinion on it. So anyway, that's that. Now, as always, our time is going at pace here. We did get a late start, but I want to make sure that we all have a chance to kind of have some final thoughts here. And Nurse Dee, we're gonna jump in there with you. Final thoughts on end of life and MS that you'd like to get across to our listeners.
Well, we talk about palliative rehab and even at end of life. So your hopes and your expectations from day to day may change, and it's moving that line in the sand, Ros, that you're talking about, and being able to move with that line and looking at what can I do today, you know, and how can we as specialists and palliative care specialists help you with doing that. That's what we ask every day. And the area of palliative care is evolving all the time. It's getting better every day. We've amazing researchers out there, and we've great work being done, and there's excellent end of life care being provided by specialist palliative care for end of life.
And thank you for being one of those providers, Dee.
Yeah.
Dr. Solari, any final thoughts?
Well, my final thought is that it is important to share with the team that is caring you as a patient, as a person with MS, these topics. And it is important to ask your neurologist, your GP, when you want to know something about your future. What are your let's say, concerns about how you could worsen your disease, could worsen, or what you will be able to do in the future. What scenarios can happen to you? We have no solid answers, but we have some issues and some information that we can share with you. And these are important also for us to better understand how the person that we are dealing with, and how to help your life in the best possible way.
And I suppose it's important to press, if the neurologist doesn't want to talk about it, but you do, tough. It's your time. We're going to talk about this. If you don't have an answer, who can I go to?
Okay.
Yes.
Yes.
And Roz, any final thoughts on this very difficult topic?
My first is at end of life, I want to be in Ireland. That's my
yes,
first.
you do. Actually, you want several years before that.
Yeah.
That's where you go after.
Second, I think that finding a way to start those conversations with your family members in whatever way you can, and reaching out to a mental health professional to help you jumpstart those conversations if you need to. And to echo Deirdre's comments about looking carefully at your lines in the sand and looking to your healthcare team to help you with tools, strategies, adaptive devices, anything that helps you function and feel better because there is always something that can be done to make something better. Not everything, but there's always something that can be done to make at least one thing better. And then the line in the sand moves.
That's brilliant. Thank you very much. As I knew it would, our time is quickly coming to an end, and you've answered really important questions that so many more could be asked. I often say this on the Unspeakable Bits that we'll probably have to have a sequel to this at some point in the future. Until then, however, I do want to extend my greatest respects and thanks to our guests, Dr. Alessandra Solari, Dr. Rosalind Kalb, and palliative nurse Dee Hickson. What you did here tonight was immeasurably important to my community, to the MS community, and I thank you for that. Folks, don't forget to mark your diaries for our next Unspeakable Bits episode. This will be the final of the year. It's on Wednesday this time. We had to juggle some pretty important calendars and diaries to get this one. On Wednesday, the 27th of November, we'll be joined by the President and Chief Executive Officers of MS Ireland, of the European MS Platform, and of the National MS Society in the United States to talk about what they see as the challenges ahead for the MS community and for our advocacy organizations in the coming year. We're honored to have a panel like that, just as we are to have all of you. So until then, I'm Trevis L Gleason, wishing you and your family the best of health. Cheers, and back to you, Fergal.
Yeah, so again, I just want to thank you. I have to say that I found it very positive conversation for such a tricky subject. You know, I really got a lot out of it. So I want to thank Dee and Alexandra and Roz, and of course Trevis again, for I think people get an awful lot out of this conversation, and just let people know it will be going up next week on our YouTube channel. So I know there's lots of people that will have wanted to see it. So if you know someone that wanted to see it and didn't get a chance, it'll be there. And also we'll have the link up for the next podcast series, or for the next webinar. So thanks again, everybody. I really appreciate it.
Thank
For giving
you.
us your time, and take care.
Thank you.
Thanks.
Take
Thank
care.
you.
Everybody.
Bye.
Bye.
Take care.